drainage with the contrast. And then again, the classic signs and symptoms that they would expect to see with that. Now, how do you treat pleural effusion? Because of the distress, we think O2. And just because you take the fluid out with thoracentesis doesn't mean that you fix the problem. As I said before, you have to treat the underlying problem and then go from there. But you can at least temporarily take the pressure off and relieve some of that distress by pulling the fluid out with thoracentesis. It won't be out of the ordinary for them sometimes to pull out a liter or two of fluid just from one side. And some patients will end up having pleural effusions on both sides. They'll just do one side at a time. They'll usually do one side on one day, and then they'll wait maybe the next day to do the other side. Chest tubes, we know, are going to drain air and fluid. So if you insert the chest tube at a lower, like at a 4, 5, or 6 mid-axillary type of position, then that's going to set you up to drain any kind of fluid, whether it's blood or chyle or just regular hydrothorax, where you just got all this extra pleural fluid that's accumulating and building up. And then, as we saw with the pneumothorax, if you've got someone who keeps having pneumothorax over and over again, as a last ditch effort, they could do the fluorodesis with the baby powder, or they could do the tetracycline. Now, more of pulmonary restrictive disorders. We've got pulmonary edema, which means that you've got, once again, an issue with too much fluid somewhere. And in this case, we've got two varieties. We could have fluid backing up into the lungs because of a poor left ventricle, like in the case of cardiogenic shock, or or any kind of like issue that leads to a left side heart issue. And all of these are pretty much going to say the same thing, meaning that it's the left ventricle that's being affected. And that's why the fluid is now backing up into the last place that it was before it got to the heart. It was in the lungs before it reached the left side of the heart. So if the left side goes into failure, things are now starting to back up back in the lungs. And then we have non-cardiogenic type of pulmonary edema. And this, as the name implies, doesn't have anything to do with the heart itself. So it's not the left ventricle that's the problem. It's just maybe something else is causing the lungs to get flooded with all this fluid. And at the top of the list here is ARDS, and ARDS is shown up at the end of this presentation. But we know that with ARDS, it's going to create havoc with all of the body systems. So if we're looking at the lungs specifically, there's going to be a change to the actual alveoli and the pulmonary capillaries. The capillaries are going to start leaking fluid, and then the alveoli, they're going to start absorbing all this extra fluid. It's also an immune kind of response that's it's like in turbo mode, where the body is just going through this vicious kind of like immune response. So then that's going to create more inflammation and more swelling and more fluid retention. And then, as you see, viruses, smoke injuries, like upper airway injuries, or just smoke inhalation in general. Lungs are full of fluid because you're like a near drowning victim, and certain drugs, and et cetera, et cetera. Anything that's going to literally cause your alveoli to be overcome with too much fluid, that's going to be a non-cardiogenic type of pulmonary edema that you're experiencing. Now, the pathophysiology is not too complicated when it comes to pulmonary edema. It just means that, again, for whatever reason, your alveoli start to take on all this extra fluid, and then you get all of this this swelling that starts to take place. And now with more fluid inside the alveoli, your your surfactant is going to be washed out. So it'll either be washed out or almost completely inactivated. So without enough surfactant, we know that that's going to mean that there's going to be a lot of atelectasis. The alveoli are not going to really want to inflate anymore. They're going to want to stay collapsed because of the lack of surfactant. Now, again, this looks like distress to me. You got the tachys, the tachypnea, the tachycardia, the hypertension, and then you got the cyanosis because of this is a VQ type of problem. You've got O2 that's trying to diffuse into the blood, but you get all this extra fluid in the alveoli, in the interstitial spaces, then that's going to act as a barrier. So you end up with like an O2 that's diffusion limited, and then they end up cyanotic. And then they become even more tachypnic because they're cyanotic or they're hypoxic. And the classic sputum that they produce, pink frothy. So these are the key words that we associate with pulmonary edema. Pink because there can be some blood vessels. Could be some blood vessels that are possibly bleeding a little bit. The red blood cells themselves are being broken down, and then you're going to end up with this pink kind of tinge to the secretions. Frothy because in order to make any liquid fluffy, you got to add air to it. Just like if you were cooking and you were trying to make, you're going to try to make whipped cream. You start off with a liquid cream, and then you have to whisk it and whisk it and whisk it. As you're whisking it, you're putting in all this extra air, and then it gets fluffy. So it's the same thing that's going on in the lungs, especially if they're on a ventilator. It's really pronounced on ventilator patients they've got a lot of pulmonary edema. You'll see the froth. You disconnect them from the ventilator, and that froth will literally start to climb up out of the ET tube. It'll start almost like a volcano that's erupting. But it's just that constant air going in and out that's literally whipping up all of that fluid to cause this frothy type of sputum, and then it's kind of got the pinkish tinge to it. The paroxysmal nocturnal dyspnea, that's just saying that, you've got shortness of breath and it will come on and you don't know when you're going to feel any relief, if you're going to feel any relief at all. Especially if you've got lungs that are loaded with fluid and you're trying to lie down, like in a normal reclining position. The more that they recline, the more shorter breath they're going to feel because the gravity is working against them. With all this extra fluid, it's literally causing them to end up with like more venous return. And then that's going to feel like, they've got this weight on their chest or they're really short of breath. And so we always will have to try to keep them in the most upright position as possible. If they've got to sleep, they've got to sleep literally like in a sitting position. And then the wheezes here, this is now your classic cardiac wheezes here. So it's not necessarily that the small airways are constricting, like in a case of like an asthma attack, or you got all these extra histamines that are being released that's causing the airways to constrict. This is just all that fluid in your small airways will create resistance. And resistance will mean that you're going to end up with, like wheezes. So how many times will the RT get paged for a patient who's got cardiac wheezing? A lot. And then the treatment option isn't to give a bronchodilator as they think it is. They'll call you and say that Miss Smith is wheezing and she needs a bronchodilator. She's probably wheezing because she's got pulmonary edema. She's got like CHF. So CHF is the classic cardiogenic type of pulmonary edema. And then all those other things that we saw under the category of cardiogenic would be like ARDS or, infection and et cetera, then either way, they can all end up with these type of wheezes. Again, I wrote specifically cardiac wheezes here because of the classic CHFer who starts to have wheezes. And what they need is diuresis. They don't need a bronchodilator. That's why you recommend when they call you, once you figure out what the problem is, you don't just comply and say, okay, I'm going to give a bronchodilator. That's not what they need. It's not going to fix the problem. You're going to need to make sure they're getting enough oxygen and they get some diuresis. And chances are they probably already have like a standing order for Lasix anyway, as needed. So then how do you diagnose pulmonary edema? Of course, you do your standard exam, and your ABGs can be helpful, but not necessarily they're going to be completely helpful, because anybody who's in distress, as we've seen with all these other problems, these other type of pulmonary restrictive issues, they'll end up with blowing off too much CO2 because they're tachypnic, which means that they'll become alkalotic. Now, this is respiratory alkalosis with the hypoxemia. So we know that with the hypoxemia, you're going to become more tachypnic to try to get your oxygen levels to go back up. But because of all this extra fluid that's in the alveoli, that again is what's going to create like an O2 diffusion problem. And then in really, really, really bad cases, the CO2 is really high and they could end up in like an uncompensated respiratory acidosis or type 2 failure. Along with your blood test, that's what they're mostly going to be probably focusing on, the BNP. The brain natriuretic peptide is just this hormone that's going to be released from the ventricles anytime that there is any kind of overstretching or even injury to cardiac cells. This hormone will be secreted, and then they look for elevated levels of BNP, and that would be classic, there's way too much fluid, the ventricles are stretching way too much, and the BNP levels are now too high. X-ray, and again, they have a 12-lead EKG, but again, I'm really not 100% sure why they would expect you to check a 12-lead EKG when it's most likely just going to show the tachy. It's going to show like a tachycardia. But I know that they would probably want you to still consider a 12-lead EKG because it could be something more significant as far as like heart problem. But for all our main purposes, I would say this is not going to be that helpful for us if you get someone who's in distress. And then cardiac catheterization, this is the NBRC, I believe, is still using the old definition of, they're still following the old definition of ARDS as far as when you're looking at your hemodynamic values. They want to say that elevated PAP with normal PCWP would mean okay, so if your hemodynamics if they're showing that definitely the pulmonary artery pressure is increased, it's elevated, it's way more than like 25 over 10 or 25 over 8. And then you look at your wedge pressure, it's like 20 something. Then you're thinking that's just maybe CHF. That's left sided heart failure. But if your PAP is elevated and your wedge is normal, well, they used to say, I think, less than like 19, but we're going to just say normal. If the wedge was normal with an elevated PAP, then they want you to think that this is just non-cardiogenic pulmonary edema, which would be like ARDS. So that's the thing about ARDS and CHF. They are literally the same thing. As far as the lungs are concerned, there's all this extra fluid, but they're caused for different reasons. So we know that ARDS is not normally associated with left-sided heart problems, but CHF is. So I think, as far as I know, the NBRC, but Kettering will let you know if the NBRC has finally gotten on board with just kind of walking away from this, because this was just not very. It wasn't very. It was hard to predict sometimes if you were just using this to see whether or not this patient really does have CHF or they have ARDS. But the NBRC adopted that because it was easy for students learning hemodynamics for the first time to be able to distinguish between two different problems that lead to the same issue, which is pulmonary edema. And you know what? I looked at the word catheterization and I just ran with it. This is cardiac cath. So of course, with cardiac catheterization, they're referring to doing the, are they talking about the angioplasty here? Let me think. No, this is just plain old inserting like a pulmonary artery catheter. So I had to like think for a second here. But yeah, this is our classic Swan-Ganz catheter with our hemodynamics. So with any of your clinical simulations, if they tell you at some point in that in the case that a pulmonary artery catheter has just been inserted, you already know what to anticipate on the next screen. As you move to the next screen, there's going to be something related to hemodynamics that they're going to want you to evaluate or assess. Because otherwise they wouldn't mention it. Now, for the x-rays, because pulmonary edema is pulmonary edema, you've got all this extra fluid, and all this extra fluid shows up as like, they call it like fluffy opacities. And we're being now specific by saying cardiogenic. So we're talking like CHF. You've got this bat wing or butterfly type of pattern that will show up on the x-rays usually. And then if it's heart problem that's causing the fluid to back up, then any muscle that ends up working harder will get larger. And then as it gets larger, it's going to become even less effective as far as maintaining our normal cardiac output. Then these lines here, these little, I just call them lung markings. And there's different kinds. They call it, there's curly A's, curly B's, curly C's. And it all depends on their orientation. Like some of them are running diagonally, some of them are running kind of horizontally. But the thing is, normally you're not supposed to be able to see them all that clearly. If they start to show up very, very clearly on the x-ray, then the reason is there's a lot of fluid that's in the lungs that's creating like a background, like a contrast type of background. And so they kind of like, they pop out more when there's a lot of fluid. So in other words, you should not be able to see these curly B lines that clearly. The bat wings, I've always had problems with just looking at this and seeing a bat, but it's supposed to be a bat. And this is a classic CHF type of pulmonary edema, where if you kind of like did a little tracing of all the infiltrates that you have, all these fluffy infiltrates, kind of looks like a bat or a butterfly. So key word, if you hear the word or you're seeing the word or they're giving you the word bat wing, then you should automatically be thinking pulmonary edema, CHF, or cardiogenic pulmonary edema. So then what about non-cardiogenic pulmonary edema? So now, one of the main distinguishing things between non-cardiogenic and non-cardiogenic and cardiogenic pulmonary edema is the heart's not involved with this problem. So the heart's going to look to be fine. There's going to be no cardiomegaly that you should be able to see. And also, you usually don't see any kind of any kind of effusions or pleural effusions for that matter. But you still see a lot of white. And that's the thing. Fluid shows up as white. And treatment, always kind of keep them up as high as possible. If they start to recline just a little bit, they're going to be more short of breath than they already are. And supplemental oxygen, as we know, we can give them positive pressure. That will help to force some of the fluid out and keep the fluid from coming back into the alveoli. So think like CPAP, for instance, that'll work really well with improving oxygenation and also to prevent the fluid from just transuding back into the actual alveoli. We know that the high ceiling diuretics are going to be their best bet. We're thinking like Lasix or maybe a combination of Lasix and another one of those different categories of diuretic. Morphine to decrease afterload. Morphine will dilate everything. It's going to dilate the arteries and the veins. And then the inotropes we know is going to be to increase contractility. And then vasodilators will help, as well as, their sodium intake. The less salt, the less fluid that should be retained because of all the extra salt. Okay, and let me see if I can quickly get through this, because if we're going to keep our schedule, we got to get this done so that we can do our lab, and then tomorrow we finish off these other diseases, and then you can have some time to get ready for Thursday. So with the pneumonia, I think there's really much that we can say different about pneumonia from what we already know. Now we know that pneumonia is going to be something that you either inhaled, some organism that you inhaled, or you aspirated. And that's how it usually goes. And it could be some kind of bacterial agent, or it can be a virus. It could be fungal in nature. And in some countries, it's not that often, but there are certain parasites that the patients will get exposed to, and then that'll cause like a pneumonia. But we know mostly, like when you're thinking about a standard type of community-acquired pneumonia, it'll be some kind of bacteria that's usually associated with it. And as far as what's happening, once you do get this organism into your body, into your lungs, however you got it there, whether you were breathing again or you aspirated it, then it's an immune response that you expect to happen. And then as the body is trying to fight whatever this is, then you're going to end up with even more problems, because that's going to create a lot of this, like they call it the exudate, that's going to be produced. And then that's going to make your VQ mismatch even worse than it was to begin with. And then with inflammation, you get more inflammation, because as these macrophages are responding, they're going to be they're going to be triggering other macrophages to come to this area as well. So it's just going to be a situation where there's going to end up being some consolidation. And it could be either like lobar consolidation, or it could just be in the actual bronchus itself. When they look at the x-ray, they could tell pretty much where the problem is. And then signs and symptoms, nothing really remarkable here. It's just like what you expect when someone's having pneumonia. A lot of patients will have pneumonia, whether they had it as a diagnosis coming into the hospital, or they ended up developing it while in the hospital, maybe trying to recover from surgery, and then they got some kind of hospital-acquired infection. Now, when it comes to what do you use to help you out? Is this really pneumonia? You know, do your physical and then check your x-ray. X-ray might be able to show something or it may not. And if the x-ray can't really show much, then you may want to consider a better test like a CT scan. ABG is so similar to all the other problems that cause distress. And your blood cultures, we know we're looking for like white blood cell count mostly. White blood cell counts less than somewhere around 10,000 or less than 10,000 is what we expect normally. But anytime that there's way more white blood cells in your culture, then that's leukocytosis. And that's like a classic sign of like there's a bacterial infection. So then you send your sputum sample to the lab because you want to see what organism you want to try to specifically target, whether it's a gram positive, gram negative, what generation of antibiotic is going to be effective. Now the bronch or the bronchoalveolar lavage is going to be your best bet for getting your sputum sample. Because just having your patient cough and cough up into a cup is not going to be that effective because sometimes they end up just spitting into the cup and it's not really a true sample from the actual tracheobronchial tree. Now, X-ray, as we know, it will usually show the problem if it's significant enough. If it's a really bad pneumonia, it should show up on the X-ray. And we expect to see white, an area of whiteness. So like with this right here, is this right middle lobe pneumonia or is it really more along the lines of the right lower lobe pneumonia? We look at like the right border of the heart. You can't really detect the actual border. It's just a silhouette. It's all kind of like blurred together. It's kind of merged together. So that would mean that this is definitely got to be in the right middle lobe because it's literally obscuring or obliterating that right heart border. If it was this way and you could see the right side of the heart, then you would be leaning toward this is probably like in the right lower lobes. But either way, it's going to show as white. And then how do we treat pneumonia? We know that standard is if it's bacterial in nature, some kind of broad spectrum antibiotic is usually the first thing that they would start with until they knew more about the organism and they could, maybe give something a little bit more specific. Or if it's a virus, we know there are certain antiviral agents that are going to be necessary. Supplement oxygen, help them with secretion removal, make sure that they're working on their IS. If anybody who needs to be working on IS, it's definitely pneumonia patients. They've got to be working on their hyperinflation and then keeping themselves hydrated as well. And then the last one here, ARDS. ARDS, you know what I'll do tomorrow is let me just start tomorrow with ARDS because I really don't want to just kind of like just rush through ARDS and say ARDS is ARDS because there's so much going on with it. And we see so many patients with this if they get really sick. And then, of course, with what's going on now with the COVID-19 cases, they did not anticipate COVID creating ARDS in these patients, but it literally has done just that. And they had to literally kind of like treat these patients the same way that they would have to treat somebody with ARDS. So we'll just start here tomorrow, and then we'll jump into our last topics, which will be, some of those like interstitial lung diseases, fungal diseases, and smoke and burn injury. And I think that's going to be pretty much it. So now we have our lab activity. And just make sure that each person submits a copy. And it's only just this one. So here's our lab activities here. And then The last part of the lab is asking you to do like a quick SBAR note on this patient. And I included two examples here because you could just do a handoff type of report. Like you're going to have to give report to the next therapist, and they need to know some of the relevant information about what's been going on with this patient. Okay, so your rooms should still be available in Teams for you to head over to and start working on this. So this will be due by midnight tonight, and we don't have anything else that I think. Yeah, yes we do. If you haven't already done midterm quiz number 2, make sure you get that done before midnight tonight as well. Okay, so yeah, it looks like all of the breakout rooms are still open. So you could just head over and someone will need to start the meeting once you get to that room. Let's see.
Oh yeah, that makes sense. Oh yeah, dude. Hey, deer over here. Hey, deer, where you going? What spot you going? Hello?
You're with Indira right now?
Indira is right now. She's logged in right now.
Oh, there you go. Yeah, we're gonna do
Yeah,
lab.
lab
I
three.
think that's I think this lab counts as 2. He said, as what he was saying in class.
Yeah. Mark already sent the. He said the first part of it. Do you guys see it?
Yeah, I seen it. So now I know he was saying something that we had to do like a soap assignment.
Yeah, that's dope. That's Mark.
Okay.
So good. I'm actually
Indira,
driving. I'm hauling
are
ass.
you going? Are you going first rotation? Yeah, because I was supposed to go first rotation, but I'm missing the first 2 days of sixth term. So
Uh,
yeah, so like that's the only because I asked, I was like, if I miss these 2 days, will I be able to make it up in time to make the first rotation? And he said no. He was like, if you miss any days inside, then you have to go second rotation. So I was like,
and
all
there,
right.
you go inside her? You go inside her, huh?
Yeah, that's. Do you know who else is gonna go to Sutter?
They said.
Do you know how many people they're accepting? Because I said that I wanted to do Sutter too, but I think I'm going second though. Really?
Generation.
Generation?
Yeah, that's what
No.
brother work at.
Oh, your brother works there?
Yeah,
Yeah,
that's what.
dang, bro.
Huh?
Because I know someone that is graduating on Friday. That's in the sixth term right now, and they
Uh-huh.
went to Generation as their clinicals, and they said that they offered him a job. They offered him a job
Oh
after
yeah,
clinical.
dude. Actually, Windsor and that generation, they hire, bro. Like they hire newly fresh graduate.
How you know how much their pay is starting over there?
They got my brother 35, I think, starting.
Oh, damn.
But I think the night differential, I think additional $5 or $7
Oh shit.
per
So
hour.
that's still pretty good
But
though.
I think it is pretty good. And then shit, when Natasha work out, that's where my partners, like most of my friends and my other brother work.
Where is it called?
The Sutter, Oakland.
Oh, you said Sutter, Oakland?
Yeah, that's where they get paid, bro. Like
How much?
shit.
How much is it starting over there?
Huh? They
How much is?
start. They would start. They would start initially 45, but with all the add-ons, you probably like hitting 65 an hour. You know?
Damn.
Yeah,
Yeah, I
bro.
think I hope. I wonder how much Sutter is paying in Vallejo.
Yeah, I don't know, but they said if it's like Kaiser or Sutter, they pay. Or John Weir, you know, those hospitals. Even bro, even Marin, they pay.
Hell yeah,
Marin
that's what I
General
heard.
Hospital. So what we're gonna do?
I haven't. I'm about to look at it right now.
Yeah.
Hold on. Wait, do we all have to type it out, or how do we do it? Okay, hold on. Let me find the Damn, I thought that I'm not gonna lie. I thought they would start higher than 35.
Huh?
I thought that they would start higher than that. Oh, I know. That's what I'm gonna try to do.
Yeah.
Guys,
They
Mr.
oh
Roper added
you
me
thought
to
like
group
higher than
3.
35?
Hello? Wait, who was that?
It's Nora.
Oh, what's up? What'd you say?
Mr. Roper added me to this group.
Oh, all is good. Wait, I forgot how to do the oxygen content. Hey, where's Mark at?
I think he's at work, but like I think he's active on the text, so he's doing
Okay.
it.
I know. I see him. I see him texting. Let me see. Is he into?
How much?
Wait. How? Wait, wait. How are you guys seeing the? I don't even see the lab. Oh, okay.
Yeah, you can go. Where? What part? There's the crackles. Is that?
What part are you guys on?
You said if there's fluids on the lungs, do we have to recommend some?
We could do chest. Could we do a chest tube or no?
I
You
think
said
we do
crackles
chest too.
earlier, right?
Huh?
You
Hold
said
on. One minute.
crackles, right? Not quartz.
Yeah.
Yeah. Pulmonary edema.
Hold on, let me see.
Oh, is that what it's saying? But if there's a bat wing.
Oh wait, is that a bat wing? Hold on. That looks like. Wait, there's two chest X-rays. Let me see one. Hold on, I'm gonna look through the let's see.
Mark just sent the rest of the first the part one. Yeah.
So are we
Yeah.
doing chest tube or no chest tube? I didn't hear you guys. No, so no. Okay.
Wait. I think you could do even with the pneumothorax. Can't you do a chest tube though?
That's what I was thinking. I think you can, but I'm not sure. I don't think. I don't remember that good.
Oh, that varicose.
Yeah.
Indira, what number are you on right now?
Because it makes sense because it already said it has pulmonary edema.
Yeah. What is that? Oh, okay. I remember him saying that. Okay. Yeah. Oh wait, on the left or the right? Yeah. No. Oh, is it telling us to do the AVG after?
The underlying condition. Because they say Mark said there's a blood clot, so we need to give some like aspirin or yeah, there you go.
Wait, so when a patient has like pulmonary edema, you could give them diuretic to help them.
Yeah.
I didn't even know. I didn't even know that. I
Can you
thought
only give them diuretics, or can you give
is this
something
the type
else?
of the case that we need to be careful on that? 'Cause, like we need to partner up with something because like you said the heart rate is what? It's elevated or not?
heart rate. It doesn't say. Wait, where does? Oh, it's sinus tachy.
Water. Yeah, okay. On side there. So we need to take care of that first before. Oh, okay. Yeah. Yeah. So that's it.
You know, for the exit exam or Indira.